We'll go back to Dr. Hutchings. This time, a really hot topic, the MRD testing in aggressive lymphomas. An overview, is it a reality or not yet?
Thank you very much for allowing me back here, and this is indeed a hot topic. And you would think that John and I had planned this, because despite the title that I've been giving, which is MRD testing in aggressive lymphomas, I allow myself, out of respect for the 20 minutes, to talk mainly about circulating tumor DNA as MRD, and to focus on large B-cell lymphoma, even though Hodgkin lymphoma is a favorite topic of mine, and perhaps some of the most intriguing MRD studies in lymphoma have been in Hodgkin lymphoma. So I'll focus on large B-cell lymphomas. These are the same one as 40 minutes ago, and I'm a clinician and I'm a clinical scientist, so I'm a tourist in the MRD space, have done some studies primarily in Hodgkin lymphoma, but I will make this talk primarily clinical, but there will be a little bit of background first before we go to the clinical data. So, zooming in on diffuse large B-cell lymphoma, why do we need minimal residual disease assessment? Because even though we've got so much good science, we still rely on quite old clinical factors to pre-treatment stratify our patients. We still use IPI after 3 decades. And even though there are improvements with cell of origin and our different molecular profilings, M7 and LymphGen and whatnot, we still don't really use them so much to select treatment for our patients. And during treatment, we then have our roughly 40% of large cell lymphoma patients that fail treatment. We're not very good at predicting them up front, and even during treatment with our conventional methods, which now include PET-CT, it's very difficult to tease out those that can perhaps be treated with less and those who need more than the conventional R-CHOP-like treatment. And then in the current era, where we have some really good new drugs, I mentioned a few of them just before, duration of treatment, for example, also could be greatly refined by good methods for detection of minimal residual disease. So there are various stages during the journey of the patient where a good and sensitive and specific MRD tool could be really, really useful. First and foremost, pre-treatment stratification, which I will talk very little about, but definitely also at interim and end of treatment after first-line therapy, and of course in the setting where we are looking to detect relapse and to guide treatment for the relapsed disease. So minimal residual disease has many names. We call it liquid biopsies or molecular monitoring. It's all about finding disease before it's clinically or radiologically detectable. And molecular relapse is detectable prior to both first diagnosis and the diagnosis of relapse. And this has actually been known for decades. It's not a new concept. These studies that I show on the right are approximately 30 years old, looking at follicular lymphoma, mantle cell lymphoma, and lymphoma subtypes where, because of the detectability in peripheral blood of circulating cells, or at least disease in the bone marrow, it was possible to use the then available methods for MRD detection in situ hybridization, flow cytometry, and the, at that point, very recently discovered PCR to detect minimal residual disease. And of course, in a disease like DLBCL, the very scarce presence of circulating cells and even cells in the bone marrow make it a little bit more tricky to use these older, more available methods for MRD detection. So this is just a chart that I made for a workshop we did at the ICML meeting earlier this year. You don't have to read all of it, it's very busy, but it's just showing some of the pros and cons of the older methods, flow cytometry and PCR, compared with next generation sequencing, which is of course what we use to detect circulating tumor DNA. And there's no doubt that NGS is of course more expensive, It also requires a team for bioinformatics, which is not necessary for flow cytometry and PCR, but it's also highly more sensitive and also can detect a much higher number of different DNA variations, of course, than PCR. And of course, flow cytometry is dependent on surface molecules. Now, this is very basic, but what is ctDNA? It's circulating tumor DNA, and sometimes it's confused a little bit with cell-free DNA. And of course, circulating tumor-free DNA is cell-free DNA, but we all have cell-free DNA in the bloodstream. Most of the cell-free DNA that we have, small fragments of DNA that are swimming around in blood, comes from our blood cells, from red and white cells, and in a cancer patient, that for the fraction of cell-free DNA coming from blood cells and other cells is skewed, even if there is no circulating tumor DNA. And what we see in patients with a rapidly progressive or widespread cancer, particularly the hematological cancers, is that you get a very high proportion, or relatively high proportion, of the cell-free DNA coming from tumor cells. And that's what we call ctDNA, which has been detectable almost since the advent of next-generation sequencing. And the first generation really coming into clinical use of ctDNA in lymphoma was the what we call the clonoSEQ platform, developed commercially by a company called Adaptive Biotechnologies, and this was actually the platform used for many of the first studies that we saw, including actually probably the best study of MRD in Hodgkin lymphoma, published in 2018 by Davide Rossi and Valeria Spina and their group from Bellinzona in Switzerland. The problem with clonoSEQ is you need a pre-treatment tissue sample to determine the variants that you then later will look at in your plasma samples, and that has, because of the high sensitivity of the subsequent generations of the platforms, including CapSeq and PhaseSeq, which I will briefly describe, you don't need the pre-treatment biopsy to determine the variants that you're going to follow for MRD. So with the later generations, which are dominating the field now, CapSeq and Seq and to some extent PhaseSeq, plasma at onset is sufficient, and of course that makes these methods much more easy to incorporate in a clinical setting. They're also much more sensitive. They're also more expensive, and with CapSeq you have the advantage of having even more variations, aberrations in the DNA that can be looked at, and it's a little bit different with PhaseSeq. Because what is PhaseSeq? This was developed by the same group of people at Stanford that you referenced, John, in your Hodgkin lymphoma studies, led by David Kurtz and Asher Lisaday and Dr. Alec. And what you do with PhaseSeq is actually, instead of looking only individually at SNVs, at single nucleotide variants, what PhaseSeq does is recognize a specific phase of different SNVs that are in phase. And this is not more sensitive than CapSeq, but the sensitivity is still, at the end of the day, increased because the availability to distinguish between real phases of detectable SNVs towards the noise or the background error of SNVs that occur in all cells. That means that you have a 10 to 100-fold better ratio between detection of the lower limit of detection of SNVs and the C of error, which will always pollute, of course, the signal. So the very, very high specificity leads also to a higher sensitivity when it comes to the actual detection limit. So unlike CapSeq, which can look at all kinds of aberrations, what you do with PhaseSeq is actually concentrate on the SNVs and only those that are in specific phases over a string of DNA. So with that, go to the clinical applications, and the first studies that really looked at CAP-seq and later phase-seq in large B-cell lymphoma were studies with MRD measured before treatment. So newly diagnosed patients with large B-cell lymphoma investigated in their plasma, so no need for a tissue sample at diagnosis. And what this study, also from 2018 by David Kurtz and the colleagues from Stanford, 2018 was a good year for MRD, you can see, they showed that the load of ctDNA at diagnosis was strongly correlated both with stage and with total metabolic tumor volume, and also with conventional risk models such as the IPI. And on the right you see also correlated well with outcome measures, in this case event-free survival. Relatively low number of patients, but really interesting study, and again using CAP-seq as the model. So the same study from the same group also looked at the patients during treatment, and as you would expect, the dynamics of ctDNA, again as measured by CAP-seq, very strongly correlated with the interim and post-treatment PET scans, because of course if it works with one measure, it also works with another. But is it better? Can it complement PET-CT? Well, look on the right, what you see is that those who are PET-CT negative at the end of treatment, which is the majority, of course, of patients with large B-cell lymphoma, if you look at their MRD status at the end of treatment, there's quite a big difference between those that are MRD positive and MRD negative at the end of treatment, and perhaps this difference is clinically useful. Now, fast forward to a very recent and great paper from, which is a kind of a interinstitutional effort by different colleagues in the US, led by Mark Reshevsky. These are 5 different prospective studies. They've gathered 137 patients from these studies with available plasma samples. And what they show, you can first go on the right, and you can see that, not very surprisingly, you see a drop of detectable ctDNA during treatment, cycle 2, cycle 3, and at the end of treatment, which is, of course, what you would expect. It's a proof of the concept. But on the left, what you see is, and here the colors mean something differently, so it's not the greatest figure in the world, in my opinion, but it shows something really interesting, which is that the blue patients, they are the ones who, during the course of follow-up, have no progression-free survival events, whereas the red dots, they represent individual patients who later go on to have a progression-free survival event. And you can really see the dynamics of ctDNA dropping very quickly in towards the 0 line in those patients who are not in their fate to have a PFS event, whereas those who will later on have a PFS event are much, much slower falling, even though some of them move towards the 0 line at the end of the treatment. And this can be read in the survival curves for the same patients. So what you see on the left is the progression-free survival according to PET at the end of treatment. On the right, in the middle, you see progression-free survival as a function of the clearance of ctDNA also at the end of treatment. But on the right, you focus only on the majority of patients who are PET negative at the end of treatment, and see the striking difference between those who remain having detectable ctDNA and those who have cleared DNA at that point. Really, really useful, I would say, and potentially clinically useful as well. So now we switch to relapsed and refractory large cell lymphoma. This is a study where we put a lot of patients on. It's the initial phase 1/2 study of epcoritamab in different B-cell lymphomas, and here looking only at those with large cell lymphomas. We, of course, collected plasma at all kinds of points because it's a phase 1/2 study, and this is what progression-free survival looked like if we divided the patients according to the clearance of ctDNA by CAPS-seq, by the way, at cycle 3, day 1. So that's after 2 months or 8 weeks of treatment. You already at this point have a pretty good separation of progression-free survival in this study. So switching to CAR T, this is a study presented almost 2 years ago at the ASH meeting, looking at ctDNA both at the first response assessment after CAR T, in this case liso-cel, so after 30 days, and also in patients with complete response lasting until 1 year after CAR T. And it's perhaps not so surprising to see that a clearance of ctDNA at day 30 is a good thing. We also know that a negative PET scan at that point is a good thing. It's predictive of long-term survival and potentially even cure. But to me, what's really interesting is that you have patients who are selected because they're in a complete response even 12 months after the CAR T treatment. Even at that point, you can use ctDNA to very clearly separate patients who, even at that late point, will eventually have a recurrence of their disease and those who will stay in remission. So I think that's hopefully quite clear to you on the right here, even though the slides went away for a bit. So looking a little bit into the future, because I was promising to give future perspectives, this was a study out of the glofitamab development program presented at the ICML meeting by Marcel Nijland from Groningen earlier this year. And it's a study which perhaps proposes the attractive model of not giving every drug to every patient. This is instead of giving glofitamab and R-CHOP or R-Pola-CHP to all patients with an IPI of 2 to 5, which of course, because pharma drives it all, will be the strategy that eventually wins. But this is just an attempt to do something a little bit differently. In this case, all comers with newly diagnosed large cell lymphoma, so even those with good risk can be included. And in this study, it was around 250 patients, if I remember correctly. And they all had a plasma sample at baseline and after just 1 cycle of R-CHOP for MRD analysis. In those that had cleared ctDNA, so that was a drop by at least 100-fold 2 log, they would just go on with R-CHOP as planned, and we will forget them for the rest of this talk. But those who had still, after 1 cycle of R-CHOP, detectable ctDNA, they would be offered inclusion into this study if they could, if they had useful variants that could be followed over time. And that was the case for roughly 50 patients, 46 patients. So they went on to shift from cycle 3 and onwards to not just continued R-CHOP, but with the addition of glofitamab, and they even had a little bit of extra glofitamab. That's a Roche thing that you remember from also the Goya study, for example. You give a little bit more antibody after the end of chemotherapy. I don't know why. And this, using the Avenio platform, again, this proved, I think, quite useful. Of course, there's no randomization here, but what you're looking here at the 20% of patients with the worst clearance of ctDNA. So I think I've already convinced you that these are the guys who are likely to do pretty poorly if they just get chemotherapy. At the end of treatment, overall response among those poor of the poorest, 87% with overall response and 73% with complete responses. And of course, this needs to be tested in a randomized setting, but it's pretty good for those that are probably even poorer than the PET positives after 2 cycles that we are used to seeing as having a relatively bad prognosis. So where are we now and in the near future? Well, this might seem a little bit Trivial, but actually the recent revision of the NCCN guidelines for large B-cell lymphoma is the first place where we really have ctDNA incorporated in guidelines, not just as a recommendation for what you should do in clinical trials, but really for standard of care. And this is in the case of patients who do not respond completely to first-line treatment and where the PET positive signal or the Deauville-5 cannot readily be biopsied. Now it's a recommendation by the NCCN that such patients undergo MRD analysis instead of the biopsy, but of course only in cases where a biopsy is not safely or easily obtainable. So I think that's the first addition of ctDNA into guidelines for large B-cell lymphoma so far. There are a few ongoing studies. There are actually very many ongoing studies, and I've just picked out 2 of those. This is the Radical study. It's coming out of the UK group. It's not a randomized study, so maybe it's a little bit difficult to say what impact eventually it'll have, but it incorporates ctDNA by phase-seq at baseline as one of the risk factors which identify patients at high risk. So all patients start with a single cycle of standard of care chemotherapy that can be R-CHOP, or because they have availability in the UK, R-Pola-CHP. And then based on preclinical risk factors, patients are identified as either high or low risk, and this will include ctDNA. And if they are high risk, patients will, from cycle 2 and onward, have epcoritamab added to their standard of care rituximab chemotherapy. So that's one study incorporating pre-treatment ctDNA assessment into the schema. And perhaps an even more interesting study is the ongoing Alpha-3 study. In this study, patients are receiving standard of care treatment for newly diagnosed large cell lymphoma. They have a plasma sample at onset using phase-seq. I said phase-seq for the previous study, it's cap-seq, but here it is phase-seq. And then at the end of induction first-line chemotherapy, if they have no response, which is of course rare, they go off study. But if they have a complete response or a partial response, so the situation where we are normally reasonably happy, they will be screened for this study with the MRD testing done at that point at the end of treatment. And those patients who are still MRD positive with a very fine limit of detection, they will be randomized into either observation or the allogeneic CAR-T of cema-cel. So a randomized study for patients who are MRD positive but in radiological remission after first-line therapy for large cell lymphoma. I think that's a really interesting study. So I think I'm out of time. We can use ctDNA at baseline to hopefully refine our pre-treatment risk assessment and help guide our choice of treatment. But so far, most of the clinical data are either for ctDNA measured during and particularly after therapy. And I've shown you a few clinical studies completed and ongoing showing the value of ctDNA in this space. And I still am grateful to the same people at home, but in this slide I've added the 3 people who've taught me most of what I know about MRD. It's Asha Lisa de Arjan Jepstra from Groningen and Davide Rossi from Bellinzona. So thank you very much.